Great. We're going to go ahead and I think get started from here because we also want to make sure today we have plenty of time for some conversation with the open mic. So, if you want to advance, Lorna. All right. So today, here's our agenda. Lorna sent out an email earlier today, and I did last week just to kind of give you all a heads up that the topic we're going to focus on today is achieving ACT Program Fidelity, and considering kind of what was going on before the pandemic and now sort of, it's not really post-pandemic and we know that, but, we're grappling with some of the same issues and also trying to kind of get ourselves back on track too. So we'll talk a bit about that. And then we also recognize that the last couple of calls, we haven't had as much time to, talk with one another, to learn what others are doing in other states. And so we wanted to have plenty of time for that. Just a couple of quick notes as to where we're going to go from here. So we will be starting a new meetup series beginning in October. So SAMHSA, the federal fiscal year, starts in October. And so our work with the Mental Health Technology Transfer Center will start back up again then. And then we'll still be held at the first Monday of every month, 12 to 1:30 Pacific, 3 to 4:30 Eastern, just like we have been doing. I'm going to put a link in the chat that tells you kind of all of the different dates as well. So if you want to put those in your calendar, you will be getting a registration link very soon related to that. And then a couple of other things we're going to be doing for this year. We're going to be holding 2 ACT stakeholder calls focused on challenges and solutions to address the behavioral health workforce shortage. We've had a number of states kind of reach out about that issue. We've also heard that talked about. I'm sure we'll talk about it today in various ways. And so we wanted to have some kind of focused time to talk about that and to, think through kind of creative ways of moving forward. We're also going to host 2 national psychiatric care provider calls. So this would be for anybody, a psychiatrist or nurse practitioner, working within your teams, within any teams really. People who are not on today can certainly join. And so please spread the word if you are working with a psychiatric care provider who's prescribing and providing services for your team or others. And again, this is focused on ACT though, specifically. So ACT psychiatric care providers. And then Lorna and I are very excited to announce that we will be launching a free online training on ACT. It's called an e-primer, which means it's kind of a 101. It's sort of just some basics to kind of get folks started. It's not meant to replace in-person training by any stretch. It's not, skills focused or anything like that. But it's about 2.5 hours virtually for anyone who needs to get up to speed or to onboard on a new team before they are getting some, in-person training or virtual training. And so that will be free. And we will be sure to keep you guys in the loop when that's ready to go. Next slide. All right, and I think most people are pretty familiar with this, but just to be clear, you're all muted, videos off. I will say a little bit later when we do the open mic, we often encourage people to, unmute and turn on their video so we can see them. We are recording this, and so in the link that I share with you all, you can also go back to view this recording or any past recordings from our past meetings, as well as the slides at that link. Next slide. And then we use our chat and our Q&A a little differently. So using the chat is like for what you did, just a little bit ago with introducing yourself. Or if you have comments that you want to make or that kind of thing, that's kind of where to put that in the chat. But if you have a specific question, it's important that you put it in the Q&A box, which is also at the bottom there. Should be probably right next to the chat. There you go. And so with that, then we can kind of track what questions are asked. Sometimes we can do a mix of both sharing verbally with everyone or typing it in. So you can also take a look at that as well within the meeting. So with that, I think we are doing just some real quick introductions. I think many of you we know very well, but I'm Maria Monroe-DeVita, and I'm with the Northwest Mental Health Technology Transfer Center and the University of Washington. And to provide training and consultation to our 20 or so ACT teams, which we call PAC teams in Washington State, and provide training nationally as well. I'm also a co-author of the Team ACT Fidelity tool, along with Lorna, and I'll turn it over to Lorna for her intro.
Yeah, so we joke that whoever gets to go second just gets to say ditto for the most part. I'm the director here at the Institute for Best Practices at UNC Chapel Hill, and am joined by 10 talented consultants and trainers who work with me to support teams here in North Carolina, but also in many other states as well. So we are super happy to be with you today and to be talking about a topic that's kind of near and dear to our hearts. And I'm so pleased by the huge representation we have with you all coming across the United States, but also many of you are team leaders, nurses, different staff on the teams. We have managers, we have people who are working with departments of Medicaid in respective states. We have trainers on here. Hi, Leah, saw you're here, and David as well, and many others. So we have people coming from different facets. Tons of fidelity reviewers I saw are here as well from different states. So this will be a good conversation, we expect.
Absolutely. And I think that is our last
That's
slide
me.
before we jump in.
All
yeah,
right.
That's you.
All right. Sorry, I was getting too caught up reading everybody who's here. So let's dig in. So we're going to be sharing some preliminary analyses from a study that we've been leading for the past 3 years. And this is just giving you a taste of some of that data. So it'll be about program fidelity. And part of the talk here today is going to be talking about kind of like, how are things before the pandemic? We'll show you data, but also we want to facilitate the conversation around now what? Because we've been living through something together. And we have been, this whole group together, coming together for these national meetings. They came out of the pandemic because we wanted to rally and provide support to you all, as we knew you needed to pivot and figure out, how do I do this intensive community-based practice when I'm not even allowed to be within 6 feet or be in somebody's home? So we're easing out of it. We're careful in our choice of language. And so we want to be talking about, like, how do we help support teams now with fidelity reviews still being part of that process? So what is this thing called program fidelity? I have a feeling that many of you do know what it is, but just to kind of restate it, it's essentially the degree to which a program includes features that are considered critical to achieving intended outcomes, but it's also excluding things that shouldn't be part of the program too. So I like to think of it as a recipe. So it's the recipe. What are those ingredients, the dose, the quality, but it's also how do you put it all together? Now, we know from decades of research, honestly, that teams that implement ACT with higher fidelity, they follow the recipe more closely, they improve the chances of getting better outcomes. Some areas more strongly than others, but overall, following the model to fidelity increases the odds that you're going to get better outcomes. Also, there's research to show that when you're serving the intended population and implementing the model as intended, it's also more cost effective. ACT is a model when you're paying for ACT at the level that's needed to truly staff a well-staffed team who meet the qualifications, it can be an expensive program. So it is important to be looking at cost effectiveness. Also, another key reason why we do fidelity reviews is we're gathering real data to identify where are your strengths, where are your needs, where can we give you targeted guidance around how to make some changes. So it's about quality improvement as well. And then also from a research lens, it helps you understand, like when I look at a study that says that they studied 20 ACT teams, if you're not measuring fidelity as part of that process, you're not totally certain whether were they really ACT or did they just call themselves ACT. So you don't know how to make sense of findings if you don't have a way to more reliably capture what it is that people are doing. It also is a framework that you then can innovate from. So ACT as a model is defined clearly. A fidelity measure takes those elements and operationalizes it in a way so that we can go measure the facets of ACT. But when teams take and they start working with a select population, they start noticing like we actually need to add a staff member that meets these needs because that's what's needed for this population. So like we do with Forensic Act, that a Forensic Act team is going to bring in more when it comes to people involved in the criminal justice system and their knowledge of that system. So that framework and doing innovations from that is natural and important part of this process too. So here we go into talking a little bit about the study. So I'm going to give an overview of what the study is. It's a big project and we're only sharing a little portion of it. Over the course of the next 2 years, you're periodically going to keep hearing pieces of this. You're one of our first audience that's hearing from this because you are the audience we want to hear about this data. Funders, policymakers, providers, trainers, you're the most critical people to understand the benchmarks of ACT services and to help think about how do we make it so it's stronger, what's natural, what is an outlier when it comes to practice. So part of the study is surveying all the states across the United States and District of Columbia and Puerto Rico to understand the status of ACT implementation in that state or area. And along with understanding how many teams, what are the sizes of the teams, we're trying to gather a whole lot of information around how are these teams funded? You know, what's the source of the funding? How are they reimbursed? Is it a bundled case rate? What's the amount? What does the bundle look like? What does it get tied to? We also are understanding things relevant to policy. Is there an explicit ACT policy? What's in the policy? Is fidelity monitoring conducted? Who leads those efforts? How does fidelity tie to anything else, if at all? We're trying to understand, is there outcome data being collected? Which outcome data? How does it get used? Workforce development efforts in the area, like how are they trying to build up a workforce, which we know is a hot topic for everybody right now. And the other one is about accessibility, which sometimes gets overlooked. ACT does not operate in a vacuum. You have to have a service that people can graduate into. You have to have reasonable referral sources that are working with you to give referrals that make sense for an ACT team. You're designed to do community-based services. Does your community have housing options for people to live in, or are you finding yourself serving people in a bunch of boarding homes and group homes? So we're trying to understand context as well that the ACT team operates within. So that's one part. And we're right now putting together state profiles. We're continuing to collect data for that part of the study. The part of the study we're going to talk about today is what we refer to as Project 2. And so we're basically compiling ACT fidelity data across all the different areas that have used the TEAM Act. So we are looking for, in this part of the study, it's purely descriptive. We're trying to describe, here's the proportion that of teams that rate like this. Here are the teams that, we're not just looking at total ratings, we're looking at item level ratings. What percent of the teams or the states are performing really well on areas related to specialist teams and evidence-based practices, which will show you more what we're talking about there. We're also digging deeper, which is probably one of the more exciting parts of this for me, I think for all of us, is around trying to look at the raw data that goes into a fidelity review and looking at things like, what is typical staff retention? What is common in terms of teams being only staffed with psychiatrists versus using physician extenders like nurse practitioners or having a combination of both? What do we see in terms of the percent of people who are assigned to payee? How common is it still that agencies or the team serve as the payee? What percent of people are involved in competitive employment or going to school that are also getting ACT services? So all the data that we're gathering is going to allow us to describe these benchmarks and show what's on average, what's an outlier, and then we can start crosswalking it to the teams or the areas that tend to be higher fidelity to compare it to the ones who may be lower in fidelity right now. So along with that too is going to be eventually exploring some possible outcome, because fidelity only matters if it's tied to good outcomes. Like, we wouldn't care so much about this recipe if it didn't have that relationship to fidelity or outcome, sorry. So let me go and move us forward. So here's the methods to this part of the study. we outreached all of the areas that we knew were using the team at. And these are areas that typically receive some level of training from us. Like we've intersected with them directly to help train and support them in using this tool. We also, with part of it is not just gathering the data from the reports themselves, which is the ratings, but we asked them to share, can you share the team surveys and Excel spreadsheets, the items that were used to actually conduct the review so we can see all of that raw data. So for those of you who've gone through reviews, know that either your team directly provided that to us or the state or whoever conducted the review would delete out staff names. So they were protecting kind of anonymity around who you were. And so we're compiling all this into a large database. Everything gets de-identified. Everything has code names in terms of who the state is. No, the agency name doesn't get revealed in any of this. All of that level gets de-identified. And so we also only looked at the most recent review before the pandemic. And we're only gathering one review per team. So if a team's gone through 3 reviews, we're getting their most recent review previous to the pandemic, which we're using as of March 2020. Sorry, I suffer from too many monitors at times, and I'm constantly trying to figure out where my mouse is and where am I clicking. So for those of you who are less familiar with the Team Act, here is the listing of all those items. So it's organized by these 6 subscales. So operations and structure, that's really, as the name suggests, it's basically how you're organizing this team. Who are you serving? How often do you meet in these daily team meetings? What is your process of identifying people for graduation and helping them move off of the team? So that's what these first group is, operations and structure. Then you have the core team. This is your leadership and medical team. So your team leader, psychiatric care provider, nursing staff. Then you have the specialist team. We focus in here on the co-occurring disorder specialist, so substance abuse specialist, your employment specialist, and then your peer specialist. There are many other specialists that operate on an ACT team, and their performance gets measured in various ways, but here we're just explicitly looking at these 3 roles. Then we have core practices. These are kind of like the fundamentals of ACT. You know, seeing people in the community, seeing people have a high level of support because you're serving a population that has more challenges with day-to-day functioning and typically benefit from more support. You're using assertive engagement strategies. You're taking on some responsibility around crisis management services. Then you have evidence-based practices. This is kind of like taking it to a capstone level where you're really trying to help with recovery. You are doing more when it comes to doing psychiatric rehabilitation services, integrated dual disorder type treatment, following evidence-based practices with supportive employment. And then finally, the person-centered and planning practices is the smallest subscale, only 4 items, but they're really at the heart of doing a closely care coordinated team like an ACT team. So it's that person-centered planning, being strengths-focused, really offering a broad array of care and doing it in a way to really promote self-determination and independence too. So it's a lot I'm giving you, especially if this is new to you. And I think there's links that's being dropped in where you can go visit the whole tool. But I'm prompting you because these subscales I'm going to show you again, but with their acronym. So OS will be operations and structure. CT is this core team. ST will be specialist team. CP, core practices. EP will be evidence-based practices, and then PP will be this person-centered and planning practices. So when we look across, we skipped this. Backing up one bit so you can see who we actually collected data from. Take the mystery away. We were able to gather data from 11 states, which is pretty remarkable. And across those 11 states, we have data on 216 teams. And actually, this data set is not yet fully built. We still have some stragglers. This will probably get closer to 230 when we're all said and done. The representation is strong. Almost half of these teams, we have nearly all their data. So all the teams are represented. for all of them except for one exception, because the one exception, I actually don't know the total number of teams in that state, so I don't know how representative it is. But for all of them, pretty much, we have at least 1/3 of their teams represented, which is a good representation for showing, especially for this type of data. The states vary quite a bit in terms of where they were at in implementation. Some of them have been doing ACT for 20 years or more. Some of them are actually just thinking about transforming some of their community-based teams to being real ACT teams. So here's for across all the teams, all 216 teams. On average, the mean TMAC score, sorry, I thought I put the labels in, but I'll do my best to eyeball, was just under 3.7 as an average across everybody. Now, if you look at these subscales, it's very common when we've looked at data in the past that these two subscales of the operations and structure and the core team tend to be higher than the other ones. And this is in part possibly because they're so foundational to doing ACT, and oftentimes are things that do get explained in policy very clearly. Who are your staffing? How often are you meeting? Who are you supposed to be serving? Then when you get into the specialist team, it's not uncommon that the specialist team, as well as this evidence-based practice team, ends up being lower. Part of that is because teams can vary in terms of how well they're trained in these different evidence-based practices, but also almost equally, it's how well the staff get utilized within their respective specialist roles. So you may have employment specialists on your team, but if they don't get to function as an actual employment specialist, that is the priority of their work, then their ratings get dropped down in terms of how they get rated in practice and various other things. And then here, this person-centered planning, remember, that's that 4-item scale that we find to be really critical in terms of, like, if you're lacking in here, it will have a ripple effect in a lot of other places of performance. You can see that teams are often struggling here with person-centered planning practices. So let's take a little bit of a deeper look, especially looking at these individual states. So, and this is pretty much, sorry, duplicative, I think, of what I just showed you, but just a variation of it, I'm noticing. But I had this, I knew I dropped in those subheadings for the labels. I know, right? So this is, yeah. So here they are with the actual scores, and the scale is different, and that's why it looks different, because it's scaled from 1 to 5 here, whereas before it was giving you a tighter scale of 3 to 5. 5 is the highest rating, by the way. 1 is the lowest rating. 3 is often considered like a big bucket of okayness. Like what can land in a 3 has much more range than what is measured for a 5 or a 4, for instance, for performance. This is where I'd like to take you. This is now breaking this across the states. So the states are de-identified. We have state A, B, C, D, E, F, G, H, I, J, K. The bar is set here at the mean across all of the teams at 3.68. So if your state is higher than that mean of 3.68, you're going to see the bar go up. If it's lower, it dips under the bar. So we have a few states that stand out, state C, D, E, and G. They're higher than that mean, whereas, say, state K is quite lower. Down below is a table that's giving you information about kind of the circumstances in that state in terms of their level of support overall for ACT. So level of support here, we operationalize this for this purpose to say, is there routine fidelity reviews happening? And this is at the time that we collected the data. At the time that the reviews happened, at that point, was that the very first review the team had gone through? Or did they have a history of getting that feedback, knowing on what to work on and make changes or not? Then also, is there clear ACT policy? Is there something written up at the state level, county level, Medicaid level that says, when we're paying for ACT, we expect all these things to be part of it? And it really is about having a policy, not just default saying, go look at the Fidelity tool. It's saying for our state, we have these expectations and we've costed them out and we're paying for these things. Then we have, do providers have access to ACT training and resources? Part of this information is coming from the surveys we've been conducting with all the states, where they're telling us, do you have access to internal TA? Or do you partner with somebody outside the state who's giving you these resources to your teams? And then the last one is kind of a judgment right now from the stakeholders that we've been interviewing and surveying for that big national study, where we're asking them, do you believe that there's adequate funding for ACT right now? Most come back and say yes. And this part's probably the least reliable, because we need to still funnel in more stakeholder perspectives to see how accurate this is. We have a few states that did say no. So as you can see, and I highlighted C, E, and G, they got yeses across all of these. And they also happen to be 3 of the 4. They're going and bringing this mean up in terms of average scores. Now, this one, I think, tells the story even more. So basically, I code these based on the states, how many yeses for support do they get? And I actually excluded the funding one for now, because I think it's the least reliable of those 4 attributes. And so if you got no yeses for these 3 level of support, you're here at the 0, 1 yes here, 2 yeses, 3 yeses. So you can clearly see that there's this incline happening, that if we compared these statistically, which I haven't yet, these bottom 4 to the top 4, that there's a significant difference when you actually do put these levels of support in place. Now, I did put some qualifying comments to 2 of them that you're like, how is it that this one that had 3 levels of support end up being pretty much where you'd expect them to be in the mix here in the middle at a 3.68? This is a state that does have a lot of support when it comes to fidelity reviews and also with policy, and has a lot of resources for training, but they had changes happen in the past several years around how these teams are funded. And it's done things in a way that kind of has undercut the team's ability to practice. And that's why they've been decreasing fidelity wise. Now, there's another state here that stands out as strong. They're one that was, dipping above that median level of average level for fidelity. This is a state that does not have explicit policy, but they have a long history of doing ACT, a long history of doing fidelity reviews, and have a lot of training resources available to the providers in that area. So it's 2 commentary on 2 states that don't quite fit with the rest of their cohort. Now, we'll be looking at where do we go from here as we're easing past the worldwide pandemic. What do we do now? Sorry, I keep thinking I'm advancing and I'm looking at one screen and the other one is not. So I'm catching up on my own. And Maria, are you taking over right now?
I think you are. I think you're continuing. And I do the last one, I think. I mean, I can.
No, I can.
Okay.
So we hear from you all many concerns that you've been having, struggles you've had, questions around like, can't we count this for fidelity? In many areas, fidelity was paused. Doing fidelity reviews during the pandemic, we were advocates of pressing the pause button. We were advocates of coming up with an alternative way to continue to provide support and review teams, but not rate them necessarily. We know in some places you found ways to just continue doing it, that you either tried out a full virtual way of doing reviews. And so there was variation in what was happening, but along the way, we kept hearing common things in terms of coming out with how do we retain these things that we've been shifting towards in the past 2 years? What do we retain? So telehealth, using phone as part of contacts was one of the bigger ones. We're always being asked. We actually were asked about this before the pandemic in terms of being able to use telehealth, especially for psychiatric care. So now as we're easing out of this, we have state mental health authorities, providers asking these questions like, should we allow some of this? We hear stories that for some people it really helped with engagement and the team found some success. Then we hear from also examples where it really was not successful. It was the patch-in we had to do. But again, this is a population that typically really does benefit from more hands-on supports, being with them, having visual observation of how are they doing, how is their apartment looking, being able to kind of really assess things. We also are hearing even more this past year about the strain on teams when it comes to workforce shortages. So teams are really kind of like speaking to the fact that, during the pandemic, when we had options for telehealth, we had staff that were comfortable with this hybrid model of being able to do more remote and find a mix there. And now when you have opportunities to move into other positions or roles, outpatient therapy, whatever it is, where you can do hybrid and now ACT is like, we need to be back out there. You have some staff who are saying, nah, I'd rather just be doing something I can do more virtual and remote, and ACT may not be it anymore. We also hear the strains around inflation, and we already have an underpaid workforce in many places, and this really hurt teams in trying to recruit and retain people in the service. And so also another question that comes up is around using virtual formats to do daily team meetings, talking through the benefits and kind of the costs that come with doing virtual daily team meetings and what latitude could be there to retain virtual meetings.
I think this is me. All right. So moving forward, what we're hoping to do is to encourage all of you, and including in our own respective states, to kind of come back to resuming and continuing with those ACT Fidelity reviews. And before I jump into the bullets, I just also wanted to acknowledge, Lorna, shared, we have a lot of kind of assumptions around, that like teams are getting back out there, and that, we kind of have this sort of post-pandemic language. And at the same time, we also want to recognize, we know that there are good reasons why many of you are not meeting with people as much in person. We know COVID is still out there. If you have an outbreak on your team, if you have lots of people, that are getting sick, and, people who have underlying conditions, all of those reasons. So we want to recognize that. We know it's so complex, and just to acknowledge that, there are many reasons why teams may not be going and resuming back in person. But we do recommend, just to kind of help get a baseline and to get back kind of on track, resuming a fidelity review. And I did include links to the TMAC, but I also included the DACs, because the Dartmouth Assertive Community Treatment Scale, or DACs, are used in many of your states, or there has been interest in using it. So we wanted to make sure that you had both tools at your disposal. And to us at this point, whatever the version is, like we're hoping that states will kind of go back to that. And, recognizing that if you were used to ratings that were a bit higher pre-pandemic, that you'll likely have some areas, especially when we think of, getting out there in the community, or frequency and intensity of services delivered face-to-face and in person, that you may be rating lower in some of those areas. And, that we're all kind of trying to get back and easing back into some stability. Some of it was caused by the pandemic, some of, the issues that were already there around workforce. Workforce has been a tough thing regardless. And, we just think this is COVID has just exacerbated that for many of our teams. And so again, kind of getting back to this, like we have a mission here, where our mission is to serve people who are, this vulnerable population, and to give them the best care and achieve those desired outcomes. And again, going back to what Lorna said, with the idea that, we're not looking at fidelity just for fidelity's sake. We're looking at it and we want to examine it because it's, the idea is that the higher the fidelity, the better outcomes. And so that's, what we're really geared for here. But using that fidelity review process also to just identify a team's needs, areas where they want to improve, where they need to improve. Also strengths, though, I think those are equally as important. And they're often the kinds of things that we identify that actually can be leveraged to make some of those changes within a team. Many states, when they do a fidelity review, they also offer some guidance. And, in my state, for example, it is the blueprint. We use, the TEAM Act as a blueprint for, guiding training and technical assistance kind of going forward. That is my team's sort of, our way of kind of keeping an eye on what's going on and what do we really need to focus on around training. But, the idea is that this has been 2+ years. We've had a lot of teams, adrift in many areas for a long time. It's a long time. Many of you are not the same teams that you were pre-COVID, right? You've had lots of turnover. And so sometimes what happens, this happens anyway without a worldwide pandemic, but, drift is a real thing, right? It's, something that can happen over time, especially if there's, no ongoing way of receiving technical assistance or booster training, those kinds of things. And so, especially just given all of that, this is kind of a mechanism to do that. Now, Lorna mentioned some of the common questions that come up. And, we get asked this a lot when it comes to the fidelity tool. And so right now, rather than making any adjustments to the scaling or the definition of what constitutes certain types of contacts or services, right now we're just still keeping it the same. And our understanding is that's kind of true across fidelity tools. But then using this as an opportunity to get a sense of like, what is going on? Like, what are, teams that are doing a lot of telehealth, what is happening with, their own fidelity, or are the outcomes, are they going up? Are they going down? We're now measuring, Lorna actually developed an electronic version of the TEAM Act called eTEAM Act. And so, through that, we're measuring psychiatric care provider use of telehealth in addition to in-person to identify trends. Like, what are we seeing in those data? And I think without those data, that's kind of what we've always said. We don't know sort of what works and what doesn't, and we can hypothesize, but we don't really know. And then what are the qualities, right? Like if having some hybrid of daily team meeting, virtual, and some in person. Well, what are there specific elements that need to be in place when you are meeting virtually, for example? So really identifying kind of the high quality way of doing these things in ways that we didn't typically do it in the past. So with that, we wanted to kind of grease the wheels, I guess, and having this be sort of a presentation and, kind of didactic form, but also a way for us to kind of open the conversations about what are your questions about what we shared or any concerns? What are some things that we would be helpful to kind of be considering? So we're going to open things up. I think, do you want to take the slides off now, Lorna, or keep it on? And so with this, you can either put a question. Looks like we have a couple of questions in the Q&A. You can also raise your hand. It's really fun. I think we've had a few of these where we've, folks have been able to raise their hand, and, you can feel free to put yourself on video if you want, but if you don't want to, even just hearing your voice, I think it just makes it a little bit easier to kind of go back and forth. So with that, let's see, I'm going to look to see, okay, our friend David has some questions here. Do you want to answer that, Lorna?
Yeah, so question asking about with regard to the study, some things like, are we looking at these things? And so one was asking about like what fidelity tool is being used, if they are using one. And we do ask that question with listing the typical ones, the DAX, the TEAM Act. We make sure that people understand the DAX is the SAMHSA fidelity tool because people think of it that way because it's in the toolkit. And then we also ask is it too, and then we give an option if there's something else that they're using, but then also we ask the extent to which it's used following the protocol, the original protocol. Sometimes we run into places that have made local adaptations to a fidelity measure to reflect the reality of their environment, which I think there's measurement concerns with doing that, but places choose to do that at times. And then we also look at, are you describing common, strong statewide implementation actions like policy, training, consultation, fidelity reviews, and gathering information regarding ACT outcomes? Yes. So we're covering all that ground. The tricky thing of doing this study across the timing of the pandemic is that we're trying to gather information about what was the status of things at the time right before the pandemic. But now that's becoming 3 years ago, and so we're going to be rounding back to the states to understand big changes that happened since then. So we know that for some states, they were in flux of making some pretty serious changes when it came to supporting ACT teams. And we want what comes out of this to be able to capture those big changes. But we are measuring all those things related to outcomes and fidelity and consultation. In ACT policy fidelity reviews, did you gather if state systems use financial or other incentives for good fidelity or other measures to address less than desirable fidelity? And we do. So we ask those specific questions. Are there any type of incentives for teams that perform higher fidelity? And then we also try to understand what are the consequences to teams that don't meet a benchmark, and what is that benchmark? And we do exactly as being asked here. We're trying to understand financial incentives, potentially repercussions, but also the things that are not necessarily financial, because there's a lot of ways to support teams that don't necessarily have to be like a differential rate. So yeah, we put a lot into trying to, I think because we're so curious and we see so much, that we were trying to go for broke when it came to trying to really understand what's happening with ACT.
So the second question, so hopefully we answered your question, David, but feel free to raise your hand. I would love to hear from you. Is from Kelly, and she says, Georgia ACT teams utilize the DAX to measure fidelity during this era with workplace shortages and low census, etc. What are your thoughts in using the DAX or Team ACT fidelity tool? Of course, we are biased, being co-developers of the Team ACT. I also see our friend Greg Teague is also, I think, here today. He's the first author of the DAX and worked with Lorna and me to adapt essentially the DAX and develop really what has become a very different tool, and would probably be the first to say, not to put him on the spot, but the first to say that he recognized that there were a lot of limitations of the DAX. I think in terms of you're recognizing, and I think where this question is coming from is, these teams are struggling, do we want to hold them to a bar that is potentially higher versus kind of keeping it where it is with the DAX? And I would say the trick, I think, of sticking with what you have is the reason that we made the adaptations we did, which is to kind of get at what do they do within these roles? What are the different team members' roles? What are the specific services that are delivered? And recognizing that it may mean, and studies have shown that you do tend to rate a little lower on the Team ACT, but it is a more sensitive measure, so that you do see improvement over time. I think it tells you more about what's happening with your team. So if the goal in Georgia is to, continue to help these teams, and it really is focused on a quality improvement and providing guidance and understanding what's happening, then I think that the Team ACT is going to give you a little more information about that. So that's my 2 cents. I don't know, Lorna, if you've got anything else to kind of add to that. And,
yeah, I was just asking also because of how the question was worded. I wasn't sure if the or part was like timing of return to begin with, like regardless if it's DAX or Team ACT, which I know has come up too, and we've been talking about throughout these past several years. And we've continued to stall in our respective states, and for the exact same reasons, that you all are citing. And we also feel a need to ease back into this. Like we are missing out on a lot of a process that's systematic in identifying how teams are doing and being able to be more thoughtful in providing feedback. I think the trick with this easing back in is really trying to soften. If there's any consequences to those ratings, that's the place to soften right now. that's the place to give teams a little bit more space to say, okay, pre-pandemic, fidelity ratings were tied to XYZ. Well, we can ease into doing the fidelity reviews for quality improvement. Can we also look at easing whatever those contingencies are that may have something to do with certification, payment? Now, in some places, it's maybe not. I know here locally in North Carolina, we have a pretty generous bar when it came to what was acceptable for fidelity for ACT. A 3.0 is already, not the greatest score. So I think we are going to be learning as we go. And, the workforce shortages out there, nobody wants teams to fail. I think that the spirit of this, we need you. We need to help you, survive through this too. So I think that spirit should be showing up and how we're returning to do fidelity reviews as well.
This next one probably is a good one for you to tackle, since this has kind of been your role in North Carolina from Michael.
Yes, I'm trying to see. Can you provide example 12? High fidelity scores are tied. So can you provide examples on how fidelity scores are tied into rates as an incentive for teams to score higher in fidelity review? So there are a couple ways in which we've seen this in states. Some states may have another level of service called by a different name, and you default are going to get paid that service at its rate. But your higher fidelity score on the ACT fidelity scale allows you to basically get an enhanced rate to reflect you're doing ACT, not this other level of care. So we've seen that. We've seen in some places they're in the process of rolling this out or thinking about it, or where they truly have an enhanced ACT rate. If you hit this threshold of fidelity, you're going to get paid even more than a team is lower fidelity. We've had many discussions about kind of like the many ways you can reframe that, where teams say you call it an incentive, but it actually feels like getting paid the lower rate is a penalty. And how can I have an even stronger team if I don't get paid the rate to be a stronger team? And I think there's some rational thought behind that argument too. So it's all about, is the higher rate truly an enhanced rate, or is it truly what most of the teams should be getting to be able to staff up and retain staff at the level needed to do ACT? With inflation, and then also with just already having wages be low for a lot of positions, and needing to be even more competitive to attract master's level therapists and co-occurring disorder specialists and nursing staff, I just feel like we talk a lot about this. This is where the conversation should be in every state. What is our Medicaid rates? When's the last time we evaluated them? What's the cost of doing this service now? I'd be trying to gather this information with providers. What does it cost to do this service? Do our current ways of reimbursement help you meet those costs? And if they don't, let's relook at things. So
how much do we pay people?
Yeah, how much do we pay people?
How much do we pay people? Yeah, that's a huge one. And with this, we should be paid the best because of how hard you all work and how complex this, particular model is, and the skills that are asked for. We should have our creme de la creme. And I know you guys are working so hard, but you should be paid in a way that's commensurate with that hard work you do.
Right. So I think that's the tricky part with when you have incentives tied to some differential rate. The other thing I'm going to put out there too is that the quality of the reviews have to be even better than they were before, because now you have less room for rater error if the consequence of an inaccurate rating means they lose a higher rate. So when areas decide to tie it, you have to build the infrastructure to have trained, competent fidelity reviewers who have levels of supervision, a process of being able to make sure that ratings are as accurate as processed, which is what we've designed here in North Carolina and had that in place for years. So when areas don't tie fidelity to any type of financial incentive or consequence, you're using it more for quality improvement. At that point, you want to have trained fidelity reviewers, but you have a little bit more room to get something wrong. The team just says, well, they clearly don't know what they're talking about, so I'm not going to take that recommendation. So it's another consideration with doing, and I'm not here to market eTMACT, but eTMACT is really going to help tighten up the reliability of ratings for areas that really are using fidelity reviews more often and as part of a process that gets tied to something like incentives or finances.
And it will make it easier for the reviewers.
Oh, a lot easier, yeah.
No more flipping back and forth in the big manual. So,
you mentioned it earlier. I think we built into eTMACT tracking of attempts, phone calls, collateral contacts. Like, we are really gathering all this data, and some items that doesn't still count. Like, it's not part of the protocol. They weren't ever intended to count. But we also recognize that there are some items being reviewed that they always could have counted. We just didn't systematically gather that information, in part because the teams didn't document those phone calls. You don't document the phone calls unless you actually really were getting reimbursed for a lot of teams. So now we are really gathering everything. And for items that's looking at, like, what's the quality of employment services, there's a phone call documented where somebody did a practice phone interview because the client's about to have a phone interview. That's fantastic. And that counts towards several items.
Let's see. So Bonnie has a great question. We're now a new ACT team. What should be our focus for fidelity in year 1 and 2? Sorry, there's an ambulance in the background here. So I think that is also actually, I think, the crux of like how the TMAC can be helpful, because if you looked at the scores that Lorna shared across states, you notice that things like operations and, structure, the core team and core practices, like all of the sort of hallmarks of ACT service, come a lot easier for teams, right? And that's where I would focus. We would focus on kind of some of those basics. We don't typically see that operations and structure is low, but somehow evidence-based practices is high. It all kind of fits together. It's in some ways sort of a Maslow's hierarchy of ACT implementation. And so really getting kind of the infrastructure in place, working on daily team meeting and what's the most effective and efficient way of conducting it. How are we communicating with each other? Are we tying the work that we do? Does it always kind of track back to the treatment plans that we've collaboratively developed with the people we're serving? Those kinds of things is kind of the basics. And then over those, years 2 and on, really focusing on the integration of those evidence-based practices. But it starts with that infrastructure. So for example, having a specific way in which you're scheduling so that your specialists are really working in their specialty role, that's kind of planned ahead of time through the treatment plan, that's over time going to increase, scores related to, evidence-based practices and person-centered practices, for example. So, it's both a question about fidelity, but I think in the end, it's really about practice, right? I think your question is specific to focusing on fidelity, but this is all about just training. I mean, this is what we spend a lot of our time doing is supporting teams and really using the tool to get a better understanding and to help them. So,
yes.
Yeah.
And I'll just do the extended plug to many of the trainers on here. So we do a lot of training, but there's a lot of trainers on here too that do a lot of supportive teams nationally.
Yes, there are. Let's see.
And thank goodness.
Yeah. So let's see. The next question is, do you have any quality of life measures to track the improvement of teams in relation to the fidelity review score? In Alameda County, we started to do more partner and family reviews. However, we have no assessment to gauge increases in quality of life, such as independence and meaningful activities. You're looking at reductions in hospitalizations and jail days, increases in community living days. Okay, so seeing more measures of independence. Well, I think, Michael, and you guys are using the TMACT, I think, but you're For one, when you're using within the Team Act, there's this Excel spreadsheet that you collect information from the teams at the client level. So for every person served on the team, as you know, I'm just saying this for anyone else who isn't familiar with the Team Act. So before the review, we have a sense of kind of who is being, oh yeah, you are using the DAX. Okay, well, within Team Act, I would say, that is one of the things, and you can actually even use something like that. Lorna, I think you guys were using that with the DAX way back in the days, like an Excel spreadsheet that just helps you to kind of get a sense of the kinds of services people are receiving, or, what kind of housing are they in? How often are they getting medications monitored? There's a lot of areas of a person's life that kind of fit with the things that you describe here in your question that just gives you a sense of that. But then you use the fidelity review process to further query, to get a sense of what's happening, as you do your chart review, as you're observing the daily team meeting, to kind of cross-reference that. So that's like at the very base level, like that's an easier way to do that. There are obviously specific measures that can also be used. Is that what you were going to focus on, Lorna? Any particular measures?
I think there's a great need for this. One of the resources I'd be looking towards to see what they're coming out with is Temple University has, for over 15 years now, nearly 20 now, I think, have had a NIDLR funded, it's called a RRTC. Theirs is on community inclusion. So a lot of their work is around how do we support people with mental illness being more integrated and included in the community. And I believe that they have probably come up with some levels of outcome measures to be able to measure this, because it's such a focus of their work. I don't think I know of any teams that have been using, but I agree. I mean, I think measures of isolation and boredom would be one of the things I'd be targeting, because we know they're probably one of the bigger stressors for people, and they get overlooked by teams. Sometimes teams don't appreciate that when you're seeing somebody twice a week, there's a whole lot of days and hours between those two visits that the individual pretty much is shut in and not talking to anybody and isolating and not like having any kind of social connections, community connections, leisure activities, work. And that actually is a huge stressor for folks. So I agree, it's an important one. I think it's been a hard one to reliably measure other than some measure of self-report. So it's trying to think of some observation. One thing that we look at that Maria was talking about, the Excel spreadsheet, that I think is a good metric to be looking towards when it comes to like helping people grow and take more ownership of things in their life, is helping people be their own payee. Are we working with them to learn budgeting skills and get the skills needed so that that payship gets dissolved? That's a very concrete thing to measure to see if a team is making progress with.
Absolutely. Yep. So hopefully that helps, Michael, just with some ideas. And again, I mean, I think even though you're using the DAX, but I think the Excel spreadsheet, and we'd be happy to share it with you, is kind of a nice kind of quick and dirty. And then you just have to validate through the fidelity review process and not just sort of take it as this is it, but really better understanding the data. So Jeff has a great question, asking about when we talk about the correlation between fidelity and outcomes, what are the specific outcomes you're looking at? And do we have that data? So yes, we do. It's there's a mix of different tools by which we have those data available. Certainly for many years with the DAX, looking at high fidelity with the DAX and being able to see a reduction in hospitalizations was one of the most consistent outcomes. We've also seen that with the Team Act as well. We also have some data that focuses on competitive employment and linkages to that. Obviously, the study is going to help a lot more with that, as is the Team Act. So the number of outcomes is somewhat limited. The third one was retention, right, Lorna?
Yeah. So as Maria's saying, like the data we collect to do the review, they're not necessarily intended to be outcome data, but you can extract and reframe them to use as a proxy measure of an outcome. So employment is one of the most straightforward ones that we're gathering that from the teams, who's competitively employed, who's volunteering, who's going to school. And so you do basically, you're looking at the population of who's being served, what percent are engaging in these things, and then you're making comparisons to other teams or across time. Retention rate, as Maria was just saying, is another one that we're using that to calculate for an item, but you can tease it out and treat that as an outcome. And we actually have looked at that, and teams who are higher fidelity do have better retention rates, and that's what we would hope to see. We've also had statistically significant correlations between fidelity and the percent of people in competitive employment too. Housing gets a little trickier with the data that we do collect. One of them that would be around congregate setting living. So we would hope to see that teams with higher fidelity have fewer people who are in some type of congregate setting, like a group home or assisted living facility. So that'll be something we look at. Hospitalizations, the only way that we have them right now, which I actually think I'm very interested to see if this does have a relationship, is during a fidelity review for the DACs and the TMACs, we gather data in terms of the last 7 or 10, whatever hospital events, and an event is an admission and a discharge. Now, that data alone is hard to make sense of when you're trying to understand the team's outcome around hospitalizations. But what we're creating is we're looking at, given this team, when they report back the last 10, how far back do they have to go to get the last 10? That's giving you data about what's the overall rate in which people are cycling into the hospital. So if I'm doing a fidelity review of a team serving 100 people, because you have to take into consideration the caseload size, and it only takes them 6 weeks to give us their last 10. And then you meet another team that it takes them up to 4 months to 6 months to give you the last 10. That's giving you hospital outcome data that we can try to help make sense of. The kick is when you're analyzing data like this, you also have to pay attention to the priority population, because the team who is serving people who are questionably appropriate for ACT, that they seem to be doing better, that team's in turn going to have a lower hospitalization rate because of that. So you have to factor that piece in. And we happen to have some of that data that we can try to use that in our calculations.
We have another question. It's come up a couple of times in the chat, so I just want to make sure we cover it. Let's see. So this is Amelia in New York. Looks like you've got, she lives in New York City, and I'm not sure how to implement ACT into the organization I volunteer at. What is your suggestion? Well, you're in luck. You have in your state an ACT Institute out of the Center for Practice Innovations, or CPI, which is based out of Columbia University and New York Psychiatric Institute. I can send you a link or put it in the chat, but they provide training to the whole state's ACT teams. You've got tons of teams. We just interviewed actually in New York for this study just a week or so ago, and you're about to get some more. So the trick is, I think, just implementing an ACT team takes resources. And so I think it would be a matter of kind of talking to the agency, if you're able to talk to leadership to find out, like, is there an RFP coming out? That's a way that often states will, basically put out and say, we want, to implement 10 ACT teams, for example, in New York State, and they must meet these criteria, and they'll get this amount of money to get started. And then that agency can actually apply and, write a proposal to potentially be one of those ACT teams. There are some organizations who have kind of bootstrapped existing services and developed an ACT team that way. But it does take a lot of commitment toward making sure that you've got all of the different team members serving in those specific roles, which are often very different roles than what you would have had in the pre-existing service that you're trying to kind of adapt or pull from. So that's one of the challenges with that versus just starting from scratch with a new team. But I would check in with your agency leadership to see if they could check in with the state on whether they're going to be, and we know there's going to be a lot more ACT in New York. So let's see. Okay, I'm going to put a link to the ACT Institute, Lorna. I think there's at least one or two others. It might just be a comment.
I'm skimming. There's a lot in the chat here. There's a question around, do we allow a grace period for teams to get the higher rate if incentives are tied to fidelity ratings? So an example is team scores low and will receive a lower rate, but they have an opportunity to keep their rate as long as they demonstrate improvement. For the areas that I know that do tie money to fidelity, and I welcome any of those areas to speak up directly, because I'm just trying to think at the top of my head the states that are coming to mind. One I don't think has been fully tested out. I think the question for me would be, so we have discussed, and we're starting to do this in North Carolina and with a few states, what we're calling remote targeted reviews, chart reviews. So we're using the chart review process to be able to look at how would teams be scoring if we're only looking at chart data for the select items we think we could come up with some reasonable estimate of that rating. And so it's using the tool in a very targeted way for the purpose of technical assistance. Now, if you're going to have a process where a team has a grace period and they can come back and say, we've made improvements, the question then becomes, are you doing then a targeted review of those areas using the fidelity tool, or are you doing a whole nother fidelity review process, which becomes much more resource intensive? And I just feel like what we have to think through is like the targeted review probably needs to be thought through in terms of retaining kind of how systematic. You're still interviewing the same sources. You still probably need to do a chart review. So I think it's trying to like preserve the data gathering of all the data to then recheck those items. And I'm not sure I've ever heard of a place doing that. So I think that would be a consideration.
Yeah, that's a good point.
The word grace, though, I'm all about it right now.
Yeah.
Grace, grace, grace. But I will also throw a caveat. That doesn't mean that you are negligent. And I think grace doesn't mean teams can get by with, I'm going to continue to be paid as an ACT team, and you're not able to do hardly any of the practice, and the people enrolled are not getting anything that even remotely looks like intensive services. So I think that's a stressor for, I hear from some of our state friends who oversee ACT, that this is still a population that needs care. And so if there's a provider who is clearly cutting corners, clearly not making an effort to try to solve some of the problems with the team's workforce, that may not necessarily be a grace situation. So I just want to put that out there too.
Well, I think that's why we're kind of where we're at, recognizing, we're not really post-pandemic, but we do have to kind of shift gears a bit toward serving these folks who need this level of service. I mean, there's a reason that we're going out into the community and we're providing services at this intensity. And a lot of the last couple of years, I know some states kind of continue to do their fidelity reviews, but I think the general consensus, has been around that grace and just recognizing, that it's been a terrible time, for ACT teams. And we heard, many of the challenges on these calls throughout the last 2 years. That's actually why these calls even started. It was to address a lot of the, questions and concerns that were coming up related to how do we deal in a COVID era? How do we, best serve people who really need, more services. And interestingly, some of you found that, gosh, some of the folks that you were serving maybe didn't need as much service. And so that's good information in terms of just better understanding, when can folks potentially transition to less intensive services, or, were they just getting by and just kind of maintaining kind of, like what was happening in state hospitals, but in, where they were living. So, really trying to kind of parse that out, so that, again, we can help folks to move on and live their best lives. So let's see. I don't think we have any other questions specific to that, but we want to encourage you, yes, to raise hands. And it looks like we have a couple, and Justin was just asking us this. So yeah, Justin, can you help us with that? Do you want me to? Oh, there you go.
Mohammed, you should be able to talk.
Can you unmute yourself, Mohammed?
Okay.
Yeah, there you are. Yep.
All right. Yeah, I have a question because you produce the productivity units. Every unit is 15 minutes unit. When in telehealth, then the units are lower as compared to face-to-face when you go out and visit them. And is there any solution for that under this pandemic environment? And
So the reimbursement rate for the unit is lower for telehealth than face-to-face?
Not lower, but you cannot technically produce more because the contention rate, the patients, how much you can talk on the phone when you can talk on face-to-face.
Got it. I think I think I have opinions on this that's more in the realm of like just continuing to question the intentional use of telehealth and substitution of those in-person contacts. So if it's being used with a select small group because this is just what works for them and you guys are finding that this is the best way to connect, then I would hope that the math works out at the end, that you not getting paid as much for the work that you're doing with those folks that rely more on the phone contacts gets washed out, because then you have all these other folks that are getting in-person contacts and face-to-face supports that end up being longer, as you indicated. So you're totally right that it can be for people who have various types of cognitive challenges and negative symptoms, like having them stay on the phone longer than 8 minutes or 7 minutes gets really trying. But when you're in person, you're able to like bring up more things, engage them in a different way. So it's hard for me to kind of weigh in on this without kind of first backing up and saying, why are we using telehealth to such a level that we are asking this question at this point?
That's correct.
Yeah, I wonder if anyone else has any thoughts on that too. I mean, feel free. It's always nice to kind of pull from the group and you know other people's thoughts on this. So does anyone else have any thoughts that might help? And maybe put in the chat that you're answering Mohammed's question or have some you want to weigh in, put that in the chat so we know to call on you if you have your hand raised. And I'll look in the Q&A because I think there's some questions there too.
Yeah, and I want to comment that Kathleen mentioned, like when we're talking about the spreadsheets and reporting data, that there's an assumption that data is being reported correctly. And absolutely right. And I think that's part of the fidelity review process, is that we don't take you just on your word, sorry, because we know that there's a lot of ways in which people put together that data. So during a process of a fidelity review, we're cross-checking this information in various ways to try to detect if maybe it was over-reported or under-reported.
Want to go to another raised hand and then we'll come back to Q&A?
Sure.
Okay.
Andre, you can unmute yourself.
Good afternoon.
Yes, we can hear you.
Hear me?
Yep.
So I've been doing a handful of fidelity reviews this spring and summer, and one thing that's come up with a lot of the teams in regards to the impact that COVID has had, some of the questions that have arisen are, is there going to be any potential long-term changes or adjustments to the team app in following years that would adjust some of the rating scales?
Great question, Andre. Yeah, I think that's kind of goes back to the last couple of slides that we shared where we're collecting those data as we speak. I think we're getting information on kind of how right now we're just on a hold, like let's keep the tool as is, and then collecting that information to then have a better sense of, okay, have some of these adaptations compromise things, or are some teams doing it better than others? And so there's some specific core practices that would be important to, specify if they're doing, it in a certain way, that we would have kind of standards around that. But it kind of goes back to like, we don't really know. We don't know what the impact has been. We have anecdotal information. We have, teams, some teams sharing that it's going really well with, doing a lot more telehealth. I've observed some teams. I was just over in New Mexico a couple of weeks ago, and knowing how well they do their virtual daily team meeting, but they have a hybrid. But then, I've observed a lot of virtual daily team meetings where no one had their cameras on, and, it was clear that everybody was distracted. So again, I think just better understanding sort of the range of how people are performing some of those adaptations, and, what's the impact on services provided, I think. Great question.
And I see that Dr. Carol van der Swag weighed in on Muhammad, and that's a great point I didn't emphasize. That part of the problem with the scenario too that Muhammad raised has to do with the unit that's being paid. Anytime we're reimbursing at small units, like 15-minute units, you're not doing very much different than fee for service, like reimbursement. So the bigger the bundle, the more you have some latitude and space to do truly person-centered care, because you're not chasing these 15-minute units to pile up and pay for the team. So that was an important emphasis that Carol brought up too.
Sorry, I was typing with.
Okay, Leah and David had a similar question about asking, have you gathered information about the roles and meaningful participation of people with lived experience in the system implementation and evaluation of ACT? So have we gathered that data? Not probably to the level that would be more satisfying to your question. So we do gather basic information about the staffing of the team, of course, and whether or not there is an expectation that people with lived experience, that typically we often refer to as peer specialists, that they are part of the team. We ask questions about whether the local state has a process of having like a certification for peer specialists as well too. I know that in Washington, Maria, you train various people in different roles on the team to be Team ACT reviewers, and I would guess peers were been part of that process as well.
Yeah, I mean, it's been offered to anyone that the team leader designates. So who will say, I, suggest you go with this person, that kind of thing. So we've had almost, I think, every role represented as our fidelity reviewers. Right.
In terms of implementation, that's a bigger question. So I think there's there could be more in nearly every state I've ever interacted with, which includes many of you, done to get the right people around the table weighing the pros and cons of decisions. So, and that includes people with lived experience, and it includes direct care providers or the combination of the two. So could there be better involvement of people with lived experience as a stakeholder to be weighing in on decisions that's pivotal to doing this service? Absolutely. Can I think of concerted efforts? I'd love to hear from you all if you've seen concerted efforts there. We here in North Carolina had been working with Lynn Legier, who is a fantastic national spokesperson for and person with lived experience and trainer. And she has been helping develop curriculum to be used to train supervisors within mental health agencies that oversee peers to be able to, like, how do you supervise a peer that's different than to help them preserve their role that's unique and not a clinical role. We've also been talking about the need for agencies to be employing peers at higher levels within the organization where they can be part of that infrastructure of support for the peer workforce that's working within the agency too. So I know there's a lot more work to be done there, but examples from anybody?
Yeah, and you can also just put it, that's a good example of just something you could throw in the chat too in response. Thank you, Derek.
What are your recommendations for ACT teams residing in areas that the clientele are often found in group homes? We're trying to add clientele, however, the appropriate clientele are often in group homes in this area due to lack of other resources available to help clientele reside independently. Ooh, that's a great question. So I don't know how long your ACT team has existed, if you've been around for a while or not, but this is a huge task. And I think you're asking the right questions around, like, part of the work of the team is really getting to know that community. Who are the landlords? Where do people rent from? Who are the good landlords, not so good landlords? What do I have available in my area for housing subsidies? Does my area have a problem with having homeless and unhoused folks, and what services are available? When it comes to housing of folks, it gets tricky because there's a lot of things that keep people in these group homes. And one of them can be guardians. So getting in with guardians and helping develop those relationships around what could be done to assist people. So they often call it in-reach services, of going out there and trying to help identify people who are in these homes and wanting to get out, because a lot of them do. They don't want to spend their life and die in a group home, especially when they're a 35-year-old person. So you're trying to help kind of like gather this process to help find the people who want to go and move out. And then, as you're talking about, you need a place for them to move to. And I think that's two efforts that need to be going on. But you shouldn't be the only one part of that effort. Your local county, city, there's people who have a stake in trying to help people not be unhoused and not be stuck in some institution. Now, the institution part is where it gets states into DOJ settlements. Nod wink to my own state, that we are in a settlement, and other states too. It's not because people were kept in hospitals too long. It's because they forever got stuck in these group homes and assisted living facilities. So there's an interest here to do the work you're trying to do and have a place for people to move into. We've seen creative efforts where the agency at large, or sometimes even like a managed care organization that's local, that they get into some relationship with a property manager that basically starts purchasing some housing options. Now, it's not to create these big congregate settings, it's to give some affordable options. And there's a firewall that exists between the service providing end of the thing and then the housing support. So it's a big question you're asking, and it's an important one. There are some states that implement ACT that they have a rule that they will not pay for ACT for people in group homes. So the system basically makes it so that's not a possibility. But for teams that are starting out and you're trying to in-reach and help people move out of assisted living home facilities, group homes, that's where it's so important that you have the support to slowly build up that team, and you're bringing on people at a rate of 4 or no more in a month, because they're going to have high needs coming out of an institutional environment, and you have to be prepared to wrap around intensive supports to help them as they ease into this different type of living environment.
I know we've only got about 6 minutes left, and you guys have had such excellent questions. And again, love people putting some ideas in the chat. That's fantastic, helping each other. And you guys are experts in this, in all areas of these questions. So with that, I actually wanted to bring up Sharice's question about how teams have been managing substance abuse groups through and after COVID, since it's been difficult to find staff to fill that role, and ways that they can still facilitate the groups with clients that live far away from each other. And so I'd encourage you to, if you are running co-occurring or substance abuse groups, treatment groups, to put your ideas in the chat if it's working well. That would be great. And I think the other thing, I know, it doesn't work for everyone, but certainly one of the things that some of our teams have done is just offering them through telehealth. So they're virtual groups instead of in person. And, it doesn't work for everyone. We know that. Not everyone has access to the technology, or using the technology can be challenging. So I think those are some of the cons, obviously, of using that model. But I know that has been one of the ways that they've been able to accommodate, especially folks living in various places. But go ahead and if others have ideas or experiences that you want to help Sharice out with, go ahead and put that in the chat. Kate has a question. what is your interpretation of the word certification regarding the member of the core team as the co-occurring disorder specialist? And can you provide examples of what certification or licensure would be needed? Yeah, that's a great question, and it really varies. So I would assume in your state you have some sort of certification designated where a provider can either be, like in some states, they're a LADAC, or in our state, they used to be chemical dependency specialists, and then they changed that to substance abuse specialists, but then they have a new certification program that's actually for co-occurring disorder specialists, which is a little more in line of what we're talking about. But in the past, we would still give teams credit for that chemical dependency or substance abuse treatment specialist role. But that's why it's kind of loosely worded. We say certification in their local, state, whatever is designated as certification to provide those kinds of services is how we defined it. So curriculum may be really different. I know in our case, when we only had the chemical dependency specialist, one of the challenges was that they didn't really know a lot of the co-occurring and kind of came from a different model, more focused on abstinence versus harm reduction. And so with the co-occurring specifics certification, there's been a lot more ability to kind of recruit for those kinds of roles. So, and if others have answers to Kate, feel free to put those in the chat as well. Let's see here. And we've got 2 minutes. So I think, Michael, do you want to answer Michael's?
So the question is regarding board and care staff, do you count engagements with board and care operators as a natural support? Because oftentimes the discussion is similar to one that would be had with landlords. I think our strict definition is if the person's relationship with the person served is involved with them being paid because of that relationship, that they aren't necessarily a natural support. With that said, we all could name tons of people who are in a relationship with us, like our own employer, that we truly find supportive. So I think that teasing it out, in the spirit of like what we care about with working with natural supports, or counting them for the sake of like frequency of contact, if all we have is landlords and board and care homes, then there's more work to do to try to help them reconnect with their mother or their sister or have a friend. So I think there's always space to help find more natural support so that we're only not hanging on to the landlord. But I think in terms of like evaluating work in terms of education and problem solving and other ways we care about how the team intersects with natural supports, at that point, I don't care if we're talking about the landlord and board and care home. So I think like be thoughtful about why we care about it. And some items on the Team Act, which I'm thinking of, we're strict in what we count. Other items, I'd be like, if you're having a great problem solving session with the landlord to support this person, I'm going to credit that in a natural support item potentially.
And I know we've only got 1 minute left, but Kate had the question about the local certification and how we define that for co-occurring disorder specialists. And just wanted to make a quick clarification point. She was asking about if they, in Illinois, you've got the CADC or CADAC, but if somebody doesn't have that and they have like an LSW or LCP or LCSW, would they still count, but especially if they have work experience? And according to the Team Act, they would not if you have a certification available in your state. So that said, if they're doing a really good job, they're going to do well on a number of items that are still going to score really highly. And even on this item, it's just 1 degree lower. I mean, they would get potentially a 4 versus a 5 if they're fully functioning in that specialty role. So it's not too tough of a hit. And I think, again, this is sort of, we're trying to just promote sort of local, for the peers, we say the same thing. They need peer certification before serving within the team, or at least, within the next 6 months after hiring. So you all, this was great. I'm out of breath. So
she was worried you all weren't going to talk much, and we needed
really
to be prepared for people to
to
bring up questions.
in a while. Yeah. I was worried. So I'm glad there weren't crickets, and hopefully we've opened the floodgates for future calls, and we'll try to do a better job of not having such a long presentation so that we can get to some of these questions for our next call. So that next call again is October 3rd, and you will be receiving a notice to register if you want to continue to join these calls. And again, feel free to spread the word, and have a lovely rest of your summer. Hopefully still sunny, but not as hot as we've all been having. So have a good one, you guys. Take care.